Greetings, everyone, from Kenya. I'm excited to join you virtually for your annual global academic meeting. I only wish we were all together in one location. I've been delayed in departing Kenya due to COVID travel restrictions, but I'm booked to depart in the morning. So I want to thank you for allowing me to join you virtually, and I'm especially honored to give you the David Patton Lecture today. I hope to share some stories of interest, including some challenging cases as well as lessons learned over the past 15 years. The first lecture will share the story of eye care at Tenwek Hospital over the past 29 years, and then two subsequent lectures are African alternative practices for eye diseases, followed by a short lecture on how to plan your eye mission. So let's get started. I think a couple of introductions are in order. First, who is Ben Roberts? And secondly, who is Tenwek Hospital? Well, I've enjoyed getting to know several of the residents who have been rotating here through the WIRE program since 2012, but there are likely many of you who are wondering who Ben Roberts is. So I'll give you a brief introduction so we can move on to more exciting topics. I grew up in a small town in South Alabama with an older brother. My dad is an engineer, my mom's a school nurse. She's the only medical influence I had before deciding on medical school. And we lived on a small farm. In fact, the tractor that I'm pictured beside here is still functioning and used by my father today. I enjoyed tennis in high school and college, and I grew up in a family of pilots. We all shared this passion for flying, though it is rare that I get to fly much today. I went to a small liberal arts school called Birmingham Southern and stayed in Birmingham for all of my training until completing retina fellowship at the University of Alabama, Birmingham. And then I moved with my wife and 3 young boys to Kenya to join a very small eye clinic at this rural mission hospital that had no ophthalmologist. And now that's where my story of global ophthalmology begins. The history of Tenwek Hospital dates back to 1937, when an organization called WGM sent Trudy Shyrock to serve as the first trained nurse. Later on in 1959, Dr. Ernie Stury and his wife arrived to serve as the first missionary doctor and to assist Trudy with the medical functions. He was the only physician for over 20 years, but was joined by other volunteers in the 1980s. Since that time, Tenwek Hospital has grown from being a small cottage hospital to being a large referral hospital, serving patients not only in southwest Kenya, but across the country and even in neighboring countries. In an effort to multiply its patient-caring abilities, Tenwek began training others by establishing an officially recognized internship training for young physicians in the late 1990s. Other training programs followed, including a 5-year general surgery residency, an orthopedic residency, a family medicine residency, and even a large nursing school. As Tenwek continues to grow, it adheres closely to its foundational pillars of providing compassionate health care, spiritual ministry, and training for service. So the birth of eye care at Tenwek was 15 years before my arrival. A man by the name of Mr. Sam Paldrel, a nurse who grew up in India where his parents were involved in community development projects, he moved to Kenya after completing a tropical eye disease program at Moorfields in London. Now his passion was community eye care development. He tells me his first patient was an outdated slit lamp. He screened patients and then recruited visiting ophthalmologists to come perform cataract surgery. Now that year, the eye department did a total of a whopping 18 cataract surgeries by one visiting ophthalmologist, but the numbers of cataract surgeries doubled every year thereafter. The first eye clinic was a small room, the same one that I found in use 15 years later when I first arrived. In 1996, a dedicated eye ward and operating room was built, which was a huge advancement. Ophthalmology, unfortunately, often takes a back seat to other specialties when located within a general hospital. So to have dedicated space to care for patients was a huge advancement in eye care. As I mentioned before, Sam's passion was community eye care. So the addition of this bus enabled screened patients to be transported to the hospital for surgery and other care. It also served as a bit of advertisement. When communities saw the bus coming, they knew to gather those blind in the community and to bring them to the Tenwek Mobile Clinic. As eye development began at Tenwek, there were three main goals for the first decade. The first was community inreach. The second, training of staff. And thirdly, quality cataract surgery. So let's look at community inreach. By definition, community inreach is reaching into the community to raise awareness, to perform eye screenings, to treat simple conditions, and refer surgeries to the base hospital. Every aspect of this is important. For instance, without raising awareness, blind people would just sit at home and not seek care. Performing eye screenings is a quick and efficient way to triage minor eye conditions from blinding conditions, and then treating those simple conditions saves people from having to travel to the hospital. And this results in a high percentage of patients coming to the hospital eye clinic that are in need of surgery. What about advertisement? Advertisement is the key to any successful eye mobile inreach. And there are different ways to accomplish this, including radio announcements, talking with community leaders, and placing posters. In our experience, the radio has been the most effective advertisement that we've done. Well, here was a common myth in global ophthalmology, and that is that blindness is an unavoidable part of aging. Many feel that the hospital is for the dying and not for the blind, and some communities are truly embarrassed by the blind. To quote Dr. Jeff Tabin from a 2016 article in the British Journal of Ophthalmology, he says, once someone goes blind in a developing world, their life expectancy is about a third that of age and health-matched peers. So, community inreach is an effective way to reach these blind. A successful community inreach clinic accomplishes several goals. For the doctor, they help to reset his or her perspective. You see, working in a hospital-based clinic, the clinician can often lose sight of the environment and the real needs of a community. But by participating in a community clinic, this helps one to regain proper perspective. This is true, I think, even in America, where community involvement helps the ophthalmologist better understand the population that he or she is caring for. And then these mobile clinics help to build rapport and trust between the community and the hospital. And finally, networks are strengthened during these clinics. Now, here are some practical steps for doing a mobile clinic. First, someone needs to address the crowd. There could be just a few individuals or a large crowd of people, but someone needs to address the crowd with the proper greetings while instructing them how the clinic's going to work that day. And then the visual vital signs are taken, including visual acuity and sometimes intraocular pressure. The tumbling E chart, now this chart is really tumbling in the breeze, but the tumbling E chart is useful for the illiterate patients because they can use their hand to point in the direction of the tumbling E. Next, examination is done, typically with a flashlight. A lot of information can be obtained with a simple light. And finally, medications are dispensed or referrals are given for the patient to go to the base hospital. Well, the second goal during the first decade of eye care at Tenwek was training of staff. Sam, and I call this the Sam era, the first 10 or 12 years at Tenwek. Sam had three main criteria for choosing someone to train for eye care in the early days. Number one, they had to have a passion for learning. They had to have a real desire to learn and to continue learning. The second thing is they must be hardworking. Sam was a hard worker and he expected all of his trainees to follow suit. And thirdly, finally, they had to be team players. See, everyone had a role to play and they were expected to work well with their teammates and be able to fill in for them if they were absent. I think the most difficult person to train was someone who could examine patients. Remember, when the eye clinic began, there was no one except Sam who had any formal training in eye disease and treatments. This is a picture of Richard. He was one of those exceptional individuals who was eager to learn and grew to be an astute eye clinician. He worked for about 25 years in the Tenwek Eye Clinic and just recently retired. Now, as eye surgeries increased in the eye unit, scrub techs were trained to assist with surgeries. They had to understand the steps of each surgery and to accurately predict the next move of the surgeon. And then circulators. Circulators had to be good organizers and understand where everything was. In the early days, the Skiot's tonometer was used to measure intraocular pressure. Now, this instrument could be a bit cumbersome to use, and it required training for people to understand and effectively use it. As in all optical workshops, patience and counseling were essential to satisfy the needs of every client. And then patient attendants had to have a good understanding of everyone's roles and demonstrate a deep sense of compassion for each patient. In the early days, when Tenwek was doing intracapsular cataract extraction, all patients received aphakic spectacles after surgery. So edging of lenses was a full-time job after surgery. So this is the team of staff from the Sam Powell era that I met upon arrival at Tenwek in 2006. Training of staff was a goal and a priority, and Sam invested much into the lives of these 10 individuals. So the third goal for Tenwek Eye Care during its first decade was the development of quality cataract surgery. As we all know, the greatest cause of reversible blindness in the world is cataracts. And these are easily identifiable and treatable in most cases. And we even have strategies that are present to eliminate cataracts as a public health concern all over the world. This was the typical cataract patient who presented at Tenwek or was found during a mobile outreach. Cataracts are a blinding condition, but thankfully they have an incredible treatment. The first cataract surgeries done at Tenwek in the early 1990s were by intracapsular cataract extraction. I personally have never done this type of surgery, but it looks quite barbaric. Though the recovery time was much longer, it was an effective way to remove cataracts. Thankfully, much has changed since that time. After surgery, all patients were given +10 aphakic spectacles. The techniques for quality manual small incision cataract surgery evolved around the world, and Tenwek adopted those changes over 10 to 15 years. Now, today I don't want to speak extensively about M6 surgery because I know Wills holds an entire M6 course, but I do want to speak about a few aspects of this surgery. For time's sake, this video is edited, but it shows the typical reproducible steps for quality M6 cataract surgery. At Tenwek, we usually use a superior approach, so we place a 4/0 silk suture underneath the superior rectus suture. And then we use conjunctival forceps and Westcotts to dissect the conjunctiva and tenons, apply light cautery, and then we make either a frowned scleral incision or a chevron-shaped incision. Either will work. And using a crescent blade, This is one of the more critical steps in the surgery. Using a crescent blade, we tunnel up into clear cornea. My preferred method, and I'll speak to this more in just a minute, of doing a capsulorhexis is an envelope method, or using a 25 gauge needle to cut into the anterior capsule. And after applying some viscoat into the anterior chamber to protect the endothelium, we use a keratome blade in the same tunnel incision to open up the incision. We call it a small incision cataract surgery. It's really a large incision. It's just if the incision is done well, then it's a self-sealing incision. And with simple hydrodissection and rotation of the lens usually is removed without any difficulty. Next, we use this incredible tool called the Simcoe. It's like irrigation aspiration, and I think it's an instrument you cannot find much in American operating rooms anymore, but it's a very useful instrument with this procedure. After placing more viscoat, a rigid one-piece PMMA lens is inserted through the wound and into the bag. And then a Sinskey hook or hook of your choice is used to dial the intraocular lens into place. And you can see that the anterior capsule was still present. We removed that and then also removed the remaining viscoat that was present, closed the conjunctiva, and that's the end of the surgery. Now, mature cataracts are ideal for the M6 procedure. This procedure can be done with less dense cataracts as well, but mature cataracts are the easiest to learn on and the easiest to teach someone how to do this procedure. There are two locations for constructing the wound, superior or temporal, and each have their advantages and disadvantages. The superior approach is easier for teaching, especially if complications occur. Iris complications are easier to correct or hide from a superior approach, but this approach also worsens against the rule of astigmatism. Now, conversely, the temporal approach usually results in less astigmatism, but intraocular complications can be more difficult to deal with. Now, there are three main capsulorhexis options: a continuous curvilinear capsulorhexis, the can opener capsulorhexis, and the envelope or V-shaped capsulorhexis. If one chooses to do CCC, you must ensure that the rhexis size is large enough to extract the dense cataractus nucleus. Now, this video shows the typical way to do a can opener capsulorhexis. Using a cystotome, many small micro incisions are placed in the anterior capsule in a circular fashion. Now, this helps to distribute the forces of any one capsular tear, and it allows for safe extraction of the nucleus. So when one finishes doing the can opener, often you can manually rotate the lens and free up the lens in preparation for extracting the lens through the wound. And finally, this video shows the envelope method. This is my personal preferred method. Using a 25 gauge needle, a V-shaped or a smile-shaped opening is made in the anterior capsule, which allows extraction of the nucleus, but the majority of the capsule is left in place. Now, here's a brief video recapping delivery of the nucleus. It's important that hydrodissection is done to free up the nucleus and to get it spinning freely. And then you can rotate one pole into the anterior chamber. It's very important to ensure that the wound is large enough. If the nucleus doesn't come easily, you need to widen your wound. And then deliver the nucleus with BSS solution when possible. I always caution people to use the lens loop or the Vectis. I use it occasionally, but you can damage endothelium quite frequently if you're not careful. What about IOL placement? Interestingly, I found that the Wills residents who are very skilled phacosurgeons sometimes struggle with placing a one-piece rigid PMMA IOL in the bag. So you need to firmly hold the IOL with the lens forceps, rotate the IOL into the bag with a Sinskey or a Lester, and then ensure that there's good centration of the IOL. So I've discussed the first 12 years at Tenwek, where the focus was community in-reach. The second goal was training of staff, and the third was developing quality cataract surgery. This was the Sam Powell era. Now, I benefited greatly from the foundation that Sam Powell laid in these three areas, but when I arrived in 2006, our goals shifted slightly and fell within these four areas: development of subspecialty ophthalmic services, construction of an independent eye center, to formalize eye education on several levels, and finally to improve sustainability of eye services. And we've all seen this pie chart from the WHO that reminds us that cataracts make up 50% of worldwide causes of blindness. Unfortunately, we have a treatment for this cause, but let's not forget about the other causes. So at Tenwek, one of our goals has been to improve our quality in all subspecialty areas of eye care. For cataract surgery, this began by introducing biometry. Tenwek was technically doing quality cataract surgery, but without the influence of biometry. So when this was introduced, not surprisingly, the post-op refractive outcomes were much more consistent. Now, phacoemulsification, though a standard in the United States, is not the standard in most of the world. So phaco would be considered subspecialty care. It's more costly and it requires a different skill set. That being said, many patients are asking for this type of surgery and willing to pay more for it. At Tenwek, we are approaching about a 50-50 split of cataract surgeries done with M6 versus phaco. And pictured here is one of your alumni, Dr. John Cropsey, and his tenure at Tenwek from 2009 to 2011. Now, when I arrived at Tenwek in 2006, the charge for basic M6 surgery was about $25, but with changes in the economy and inflation over the years, we now charge about $200 for M6 and $500 for phacoemulsification. That being said, payment varies. One of our commitments is to never allow a patient to walk away blind who could benefit from surgery. So some of our patients pay with other means. I'll never forget the first patient who brought me this rooster for payment after his surgery. So what about retina care? Well, there were two reasons that I chose to do a retina fellowship before moving to Africa. One is that I love retina. I love the treatments. I love the surgeries. But the second was that I knew that I would likely not have anyone to refer to for diseases in the posterior segment. So how do you introduce retina surgery to a staff who has only ever done M6? I mean, you have a vitrectomy machine with a push-button screen. My staff had never had any machine where you had to push the buttons. At the time, we were using a handheld contact lens, which was heavily scrub tech dependent. And you have disposables, which must be re-sterilized if you're going to be sustainable doing retina in Africa. Well, the first step was preparation. I knew initially that retina surgery would not be affordable for the patients that I was caring for, so I saved all the disposables, the tubing, the cutters, the forceps from every surgery that I was involved in during fellowship training, and that was about 1,000 cases. the next step was procuring hardware like a suitable microscope. This is the microscope that I found upon arrival to Tenwek. It did not have coaxial lighting, and I must say the first few retina surgeries that we attempted using this microscope were, let's just say they were quite challenging. The first scope that we procured after arriving in 2006 was this Zeiss Omni CSXY that you see on the left. The body and the mechanics were a bit slow, but in my opinion, Zeiss optics never become outdated. A few years later, we purchased this Visu 200, which is still a couple of generations behind the modern Zeiss Lumira 700, but it's serving us very well today. And then we needed a vitrectomy machine. Now this is the Alcon Accurus, and in 2006, this was the best technology that Alcon offered. And we felt very privileged to have this machine in our facility. Now the roads to our mission hospital were pretty bad in 2006. So when I was procuring the Alcon Accurus, I elected to fly the Accurus in by a small plane to minimize any damage on the rough roads. Now there was quite a crowd that assembled to see what was being delivered that day. Also, a multifunctional laser is vital when caring for retina patients. This is an Iridex, which has been a workhorse for the past 15 years with both indirect and slit lamp capabilities. Now, for many years, most all of our PRP lasers were done using the indirect method after giving a retrobulbar block. I've observed that all the Wills residents who rotate in our facility have already had experience doing PRPs using the indirect. I think that's tremendous. We've since added a Pascal laser, which has increased efficiency and comfort for the patient, and we no longer block patients for doing PRP. I'll admit that the first few retina surgeries were very painful. I mean, managing the vitrectomy machine, training the scrub tech, convincing the patient to be still and quiet, and many other obstacles. But with perseverance, retina surgeries started becoming routine, like doing consecutive bilateral macular hole surgery, as you see here in this patient. Infectious retinopathies, which were rare during my fellowship in the States, like this Toxocara granuloma, they were seen much more commonly in this population. Or how about these choroidal tubercles in a 25-year-old man being treated for TB in our hospital? This presumed ocular tuberculosis resolved nicely after instituting systemic TB treatment. Or how about these subretinal railroad tracking seen in a patient with ophthalmomyiasis and an active larva moving about, you can see just nasal to the optic disc. So slowly, we were consistently doing retina cases every week. But not every patient who presented at our clinic had a retina problem, unfortunately. So our goal still was to develop comprehensive subspecialty eye care. Now I know all the residents recognize these books. It's the AAO's BCSC series, and they probably do not conjure up pleasant feelings, but I was really thankful to have them as reference books as we sought to provide comprehensive eye care. So what about pediatric eye care? What do you think? What's the most common PEDS problem referred to pediatric ophthalmologists? Well, in the United States, it's likely esotropia or some eye muscle problem. But at Tenwek, pediatric cataracts are the most common pediatric done besides eye trauma. So the technique that works well for us is to place a trocar cannula to allow access to the pars plana for opening the posterior capsule at the end of the case. We then use a clear corneal approach, a CCC Rexus, and simple irrigation to wash out the lens. And we'll discuss this in a later talk. Now, congenital glaucoma is also a common presentation. It's a difficult problem to treat, especially when advanced like this case pictures. At Tenwek, we treat with a combination of medications, goniotomy, trabeculotomy, Ahmed shunts, and even sometimes micropulse laser. This is a 9-year-old boy who developed a right sixth nerve palsy immediately after a motor vehicle accident. Now, at the time, he could not afford an imaging study, so we followed him for monthly for about 7 months without any improvement. His pupil exam was normal, his anterior and posterior exam was normal, so he had what we would call a presumed traumatic sixth nerve palsy. These are types of eye muscle transposition procedures, and for this child we elected to do a Hummelshine procedure. And this is a muscle transposition where we take 50% of the superior rectus and 50% of the inferior rectus and transpose them, suturing them beside the insertion of the lateral rectus. So you can see postoperatively, he still had limited lateral movement, but he was orthotrophic in primary gaze. Now, Tenwek has a very limited ventilator support for preemie babies, but we miraculously have survival of some very young babies, sometimes even 25 weeks young. Historically, we've only treated about 12 babies a year who present with retinopathy of prematurity, but with the introduction of surfactant leading to increased survival in these babies, we're seeing many more cases of ROP. Our screening protocol is to examine all babies that are less than 1,500 grams at birth and who have been alive for a month or longer within the hospital. And then we use a combination of laser and or Avastin to treat the type 1 retinopathy of prematurity. What about cornea disease? Well, at Tenwek, our top 4 corneal presentations are herpetic eye disease, keratoconus, trauma, and tumors on the cornea or surface of the eye. This is a 35-year-old HIV positive lady that presented with a white mass growing on the conjunctiva of the right eye for the past 4 months, and it was felt to be a squamous cell carcinoma. And here is her immediate post-op photo after doing a complete excision with partial scleral dissection, applying cryo to the edges, and using, I think, what the Shields describe as their alcohol technique as well. This is a similar patient who presented with a large conjunctival melanoma. After complete resection, we were left with a large conjunctival defect. So we did a conjunctival autograft from the same eye, taking tissue from the conjunctiva underneath the upper eyelid. So in the area of cornea surgery, we had great need, but the resources and the skill set seemed out of reach for rural Kenya. But things changed in 2010 when Dr. Hanish accepted the invitation of Dr. John Cropsey to join us for a couple of weeks. We basically had 3 main requirements to begin doing corneal surgery. We needed some type of expertise, we needed instrumentation, and we needed tissue. So in March of 2010, Dr. Hanish stimulated donations of tree fine and cornea instruments, and he brought about 30 corneal tissues with him, and he provided the mentorship and the training to get Dr. Cropsey and myself back into the practice of doing corneal transplant surgery. That week, I remember we did about 22 PKs, 2 endothelial keratectomies, and 2 Boston K-pros. Now, we helped us obtain the basic instrumentation needed for corneal grafting surgery. This you may recognize as the Hanna tree find that we're still using today, 10 years later. My staff like to call it the Hannish tree find. So, regarding the corneal transplant program, could this be sustainable for a rural mission hospital setting? I mean, we had a long waiting list of patients needing transplants. We now had the instruments. We have mentorship and training, but what about the tissue? Kenya at present does not have a functioning eye bank. There is an eye bank at Lions Hospital just outside of Nairobi, but unfortunately it's really not functioning. So currently we're dependent upon U.S. eye banks for donated tissue. So practically we keep a running waiting list for transplantation, and when an eye bank has excess tissue, we arrange FedEx shipment to our doorsteps, which is an average of 4 days. Now, keratoconus is the most common indication of corneal graft surgery at Tenwek Hospital. And since March of 2010, we've done almost 400 corneal transplant surgeries. Now, our goal is to provide affordable transplants for the people of southwest Kenya. Currently, we can only provide this service when the tissue is donated from an eye bank. Now, you may have heard of the Global Site Network. It provides us with glycerin corneas that have a 5-year shelf life that are great for repairing globes when fresh tissue is not available, and they're also very useful for covering shunt tubes. What about oculoplastics? Most of the demands in this subspecialty fall within orbital infections or tumors. There's not many requests for cosmetic blepharoplasties. At Tenwek, we see a lot of pus, preseptal and orbital cellulitis. Most of them resolve with IV antibiotics, but some require drainage as well, drainage and antibiotics. Our clinic also sees its share of lumps and bumps. This is a dermoid cyst in a young lady. Remember, the goal is to always remove the entire capsule intact if possible. As many diseases, orbital pathology often presents very late. Here is an example of an orbital squamous cell carcinoma in an HIV patient on your left, and also a young child with rhabdomyosarcoma. What about glaucoma? Well, glaucoma is a very, very difficult disease to follow and to manage in Africa. I mean, we now have medications. Originally, when I arrived, we only had Timolol, but we now have a variety of medications, but they're not always affordable. So we use a combination of our clinical exam, visual field testing, OCT of the optic disc for diagnosis. We pretty quickly move on to surgical management if the patient cannot afford the medications, and this may include just simply cataract surgery, or doing trabeculectomy, or placing shunts, or some type of ciliary body destructive laser. Now, this is a typical picture of our glaucoma patients. The patient presents with light perception vision in one eye and 2400 or worse vision in the other eye. So when glaucoma is uncontrolled on available drops, we turn quickly to our surgical options. We aim at a lower IOP, sometimes almost hypotony, in the early post-op period in a trabeculectomy patient. We do have a reliable source of 5-FU and a less reliable source of mitomycin C. Now, Dr. Ahmed has been very generous to help us with shunts through donating these shunts. Several years ago, he commented that out of the over 1 million OMID valves that have been placed worldwide, he has donated over half of them. So it's very commendable for what he and New World Medical Incorporated are doing. Now, our capabilities in the area of neuro-ophthalmology are ever evolving. Prior to 2009, we didn't have a CT scan, so often we had no way of imaging patients who presented with neuro symptoms. And then in 2009, we got a CT scan and could actually see and diagnose many of these problems, so we had no way of effectively treating them. Then in 2017, we recruited a neurosurgeon to join our team, so we actually are able to treat many of these diseases that we encounter. Here's a young man who presented with slowly progressive loss of vision. He had pale optic disc and bitemporal visual field defects, and he had this large pituitary adenoma that was successfully resected by my neurosurgery colleague. Now, the second goal after developing quality eye care involved constructing an eye center to meet the needs of Southwest Kenya and beyond. And this was a long process. You can see our timeline there on the screen. Well, an engineering and design team spent two weeks with us in April of 2009 surveying and drawing up initial plans. Designing and dreaming was a lot of fun, working with this team of architects and engineers. Then after assessing our site, our needs, and our potential future growth, this is the building design that they recommended to us. And here's another bird's eye view of the building prior to construction. The next challenge was raising the $2.6 million estimated to complete the project. Now, we did have some private donors, but a large percent of the funding came from your tax money through the USAID. We successfully landed two successive grants, which enabled us to begin construction in April of 2014. I learned a lot as I observed the construction of this building using homemade scaffolding. All the rebar was cut and bent by hand, and all the concrete was mixed and poured by hand. But the finished product is now this 60-bed facility with a large outpatient clinic, a modern operating room, and a growing staff to help with the increase in patients. We were even honored to have the President of Kenya to officially open the building in April 2018. This project was definitely a family affair, and I credit especially my wife for helping me stay rational through the trials and the delays experienced during construction. Now, another major goal since 2006 has been to develop more formal ways of educating others to deliver quality eye care in rural Africa. So there's several different models, each having their own advantages and disadvantages. The first I want to discuss is a university-based Masters of Medicine Ophthalmology. This is what currently exists with the ophthalmology residency in Nairobi, Kenya. So the advantages are that you have local and regional accreditation is easier to get, and you have national physicians training national residents. It's often backed and funded by the government. Then the graduates are used to staff governmental facilities where the greatest need is. And it often serves to train ophthalmologists from other countries who don't have residency programs. And it can be recognized regionally and internationally. But the disadvantage that I've observed is that clinical mentorship often varies, and the surgical experience is suboptimal. Training is often focused simply on the most common problems that exist. And then there's also a limitation in resources given by the governmental budget or some NGO participation. So what about a mission hospital-based residency program? There's usually greater access to resources. There's connections with international subspecialists, and one would have access to more modern clinical, diagnostic, and surgical equipment. And often at a mission hospital, the training models that of Western countries, and it's usually more clinically focused, including surgical competency. But the disadvantages are that accreditation can be more of a challenge, and there can be staffing irregularities. For instance, I'm soon to leave for a one-year furlough, so there can be gaps in the consultants who are present during the training program. And the resident salaries are often less than that of university programs. We've had the honor of recruiting 2 national consultants to work at Tenwek, one comprehensive and one retina surgeon. This has been a tremendous value to our training capabilities at Tenwek. What about ophthalmology fellowships? Well, this is an opportunity for young ophthalmologists to gain experience and expertise in specific areas. They can improve their competency in the clinic and in surgery and gain confidence. COEXA, which is the governing body here in East Africa, is in process of approving fellowships in vitreoretinal surgery, glaucoma, and pediatric ophthalmology. And then there's this informal training category of mentorships. They are not officially recognized by the regional body, but they serve as a way for young qualified ophthalmologists to gain experience under a team of more established practitioners. So what's the current training programs at Tenwek? Currently we have a partnership with the University of Nairobi, and we provide 2-month clinical rotations for all of their residents. We have an ophthalmology clinical officer training, which is a 6-month program for a cataract surgeon. We offer something called an ophthalmic skills upgrade course, which is a 3-month entry-level eye course. And then we help train ophthalmic nurses as well. So that's a condensed story of the first 3 decades of eye care at Tenwek Hospital. We're in the process of developing updated goals for the next decade. Ophthalmic education will be central in those goals. We've really enjoyed the relationship with Will's Eye, especially the residents who have participated in the WIRE program. So thank you very much.